Hello, everyone. This is Bella Mehta talking from New York. I am here to talk to you about an interesting rheumatoid arthritis case, and get right into it. So, this was a 56-year-old woman with long-standing history of seropositive erosive RA with pretty severe damage. She was likely untreated or you know, suboptimally treated for many years. Um, Initially because she was not diagnosed appropriately, and even after she was diagnosed she had other complications, so we'll get into those complications pretty soon. But she came with severe deformities, severe joint damage, um, and in the past did not respond to multiple oral medications. She was never consistent, at least early on in her history, or early on when she was diagnosed with medications, because she was always worried about medication side effects and whatnot. At some point, about 2 or 3 years ago, she started having lower extremity ulcers. These were angry, huge ulcers, painful in bilateral lower extremities, um, around the shin all the way to the ankle. Um, these were open wounds, and we always kept having infections on top of these open wounds, which needed antibiotics. These are patients which are typically co-managed with wound care, because they need dressings all the time, changing of uh, topical wound care solutions, antibiotics topically or orally otherwise. So because of this, there was a lot of confusion about um, what would be the optimum medication regimen for this patient. Too much immunosuppression sometimes would cause infections, and then too much of antibiotics and stopping immunosuppressions made the RA worse. We also had a biopsy of those wounds, which showed clear rheumatoid vasculitis. So we knew this was rheumatoid vasculitis, which was getting infected on and off. Now, over time, with very careful titration of steroids, immunosuppressants, those wounds finally healed about 6 months ago, and patient could get stable on immunosuppressives. So the patient was then on Enbrel weekly uh, and subcutaneous methotrexate. So, this is a patient that had a rough course, was diagnosed after many years of having the disease, had a lot of joint damage, had complications of rheumatoid vasculitis in the lower extremities, and now finally stable um, on two medications, the Enbrel and the methotrexate. The patient comes in to us with pain while swallowing, pain while eating. When we examine the patient, we see a huge 0.5 by zero point 0.5 centimeter ulcer on the hard palate. Very angry looking ulcer. And, this is the time where we start questioning, like, is this where is this ulcer coming from? On the same day when we saw the ulcer, the patient did complain of some joint aches and pains, with two swollen and three tender joints. So not a lot of disease activity, but still some active joints. um, so I think the problem at hand, and that's something that I would want to discuss, is the ulcers in the mouth. So a huge ulcer. Also, this patient had a history of long-standing history of smoking. So a past history of smoking, past history of all these infections. Um, it 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 does give us some differential diagnosis. So our differential diagnosis was infections. This could also be fungal infections in immunosuppressed patients. Um, the patient could have malignancies, which is also one of the differential history of smoking with being on different medications does put you at risk for malignancies. Um, and we were thinking of sending the patient to ENT to get a biopsy because at this point it was like this huge painful ulcer. Um, However, we wanted to make sure that we go back and figure out what else can we test for or treat for while the patient waits for an ENT appointment. Um, so on careful history, we figured that about 3 or 4 months ago, patients started having intolerance to oral methotrexate, and we switched the patient to subcutaneous methotrexate, which the patient, you know, figured out how to do it themselves and was pretty compliant on the current set of regimen. But on careful history, what we figured out was that the patient was not taking the folic acid every day, instead just taking it once a week with methotrexate when the patient was switched from oral to injectable methotrexate. And thus, I think the patient was not getting enough folic acid too. And methotrexate has a known side effect of oral ulcers. Usually, those ulcers can present like quickly. There's a small, shallow ones, but this one was pretty big and deep. But so while we were waiting on the ENT appointment, we decided we need to do something. Since we found this in the history, we stopped the methotrexate completely. Uh, uh, you know, got the patient back on folic acid as well as folinic acid, just to see what happens. And within a week of being on that regimen, patient significantly improved. The pain was much better. Obviously, we gave symptomatic things to the patient like lidocaine, gargles, and whatnot, because these ulcers can be pretty painful. Um, all in all, I think the patient overall did well. But we were worried about vasculitic ulcers and malignancies, and a simple history, and just going through things in a much more comprehensive way helped us a lot. So with that, I think there's three main teaching points here. I would say, one, careful history and physical exam goes a long way in all our patients, especially rheumatoid arthritis patients. And it, the mainly sometimes it's not just the disease but also the medications that we give our patients, and not only we, even other physicians co-managing these patients give to the patients, which can cause oddball presentations. So we need to be mindful, do a med reconciliation, and see if any of the medications can tell us or can lead us to some of the presentations. And lastly, something that I learned, like, methotrexate can cause pretty painful ulcers, and folic acid, even though is just a vitamin, as a lot of physicians or even patients say, it is so important and crucial when taking methotrexate. And I would recommend all patients to be counseled about this, and every visit make sure that the patient is taking both methotrexate and folic acid. So with that, thank you so much for watching, and hope this helps you manage your patients better. And uh, you can follow me more at Bella_Mehta on Twitter. Thank you.